All right, good evening, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, and I'll be your moderator. Tonight, we're joined by Dr. Roy Shelburne. Dr. Shelburne will discuss the 7 most common reasons insurance claims get denied and how you can fix them. At any point during the webinar, if you have a question, please type it into the Q&A section of your control panel, and we'll do a live Q&A session at the end. Henry Schein is not offering CE credit for viewing or attending this presentation, live or on demand. And lastly, this webinar is sponsored by Henry Schein's Dental Business Institute, as well as eAssist Dental Solutions. So with that, I would like to welcome Dr. Shelburne.
Good evening, Adam. Thank you for the invitation. Appreciate being here. Look forward to the next 45 minutes, hour of being with you. Please don't hesitate if you have questions, add those in the question box. We'll try to deal with as many of those as we can at the end. Don't be shy. If there's anything that's not clear, we want you to have a total understanding before we finish the presentation tonight. I'm going to be talking about the 7 deadly sins, 7 things that you can do that would either cause denials or delays in your insurance payments. And certainly that's never a happy day when you get a denial or a delay or a request for other information. So we're going to deal with some of those issues. I want to thank eAssist for allowing me to do this. eAssist is about delivering peace of mind. And for more than 10 years, eAssist has been putting money back in the pockets of the dentist, reducing stress for their teams and creating more reliable cash flow. The team is 1,354 dental billing experts serving over 1,900 dental offices and DSOs. Today, eAssist has collected more than $6.67 million from insurance companies for their enrollees. So the company's been around for a while. It has a huge foundation and does great work to take that piece off the mind and the stress away from practices when they're dealing with insurance. Some of the awards that eAssist have received are listed here: Inc. 500, Inc.'s 5,000, the CDA endorsement program, 360 Empowerment. Financial Times has recognized them a great place to work, certified in 2020. Fast Growing 50 and Fortune 100 are just some of the recognitions that eAssist has received over the years. And most people, if you're aware of eAssist, you know that we provide dental insurance billing and aging service. But something that you may not know, in the whole suite of products that eAssist offers to dentistry today, we have a newly formed Dental Coaching and Consulting Institute. The American Dental Association did a survey to the dentist, and they wanted to know the thing that they needed most help with in their dental practices. And we were kind of surprised, but the greatest percentage in the responses was to find a dental consultant, a coach that would come into. So eAssist is spearheading that. We have a group of very amazing consultants led by Lois Banta, and we are available to help practices internally to grow, to become more streamlined. We offer credentialing for dentists, insurance verification. That's something that most practices hate to do. Sitting on the phone, waiting for somebody to answer to give them a verification of benefits. Also offer accounting and payroll services, so we can take that off and so that it can be plugged in more appropriately into an accounting system. Patient form statements and billings, patient portion, that means that eAssist actually has a division that will contact patients who have balances to collect them for the practice. So that's another thing that most practices struggle with, is making that phone call to that patient who has something in the arrears, but this is a service that is provided. And last but not least is full schedule. We have individuals who are devoted, can go into your software and be able to reappoint patients who are late for their recalls, who have pending treatment. That's taken off the plate, and they guarantee that there are a certain number of appointments that are made as a result of you contracting with eAssist. Those are some of the other things that you may not know about eAssist and the services that are provided. And I'm a dental consultant. I'm a dentist, a practice owner, a father, a husband, and a convicted felon. I went to prison for healthcare fraud, racketeering, and money laundering. Learned a lot in the process and have become an American Dental Association recognized subject matter expert on documentation and billing and coding. I share my story not because I'm proud of it. I share my story because I am passionate about being the last dental professional who goes to prison for ignorance. Ignorance is no excuse. So I want to educate the profession so I'm the last dental professional who suffers the same consequences I have. And I want to help you maximize every penny of legitimate reimbursement, no more, no less. And I want you to do it in a way that is easy, that is structured, and that you don't have to worry about going through the same torment that I did when I was arrested and was then tried and then spent the 19 months in federal prison. So, like I said, I share my story not because I'm proud of it, because I want to be the last dental professional who goes to prison. So, what we're looking for you to learn today are the 7 most common issues that lead to denials and delays from insurance companies. We don't want anything denied. We don't want anything delayed. We want it to be a clean claim going into the insurance. And if it is something that should be reimbursed, it is reimbursed, one and done. How to avoid unnecessary denials and delays to improve practice profitability and have a steady cash flow. It's important that money in, money out, that you are paid what you're supposed to be paid in a timely manner with as few delays or denials as possible, because it takes twice as long to deal with the delay or denial that it does to submit that claim initially. So that's going to help streamline the process if you do things right the first time. And how investments in the revenue cycle management solutions will result in long-term gains for the practice and benefits for the patient. So we're going to work to make sure that the practice benefits, the patient benefits, and that the team benefits, and that things are done more streamlined. So we have a poll. So I'm going to go ahead and let Adam go ahead and take care of that. Want you to use your software to be able to choose answers to these questions. Does your office utilize a billing and coding resource? Let's say an up-to-date resource, one that is a 2021 reference. Do you have one in your practice? We want to know how many of you do. So Adam, if you want to take this over and take care of that.
Absolutely. The votes are pouring in. Let's give it a little more. It's looking like the majority do, in fact, utilize a billing and coding resource.
Good. So we'll give it a little bit more time. I sad to say, there are so many times that I find that practices have a coding reference that is 2, 3, 4 years old. And it makes correct coding and utilization of those codes so much more difficult if you don't have the supportive information to use the most current coding reference. And it's sad to me when I see that. It's one of those small investments. It's penny wise, pound foolish. It doesn't make any sense not to invest every single year in a new coding reference material. So what were the final results?
They should be showing. 61% said yes, 35% no, and
Okay,
4% I wish.
good stuff. Yeah. Point number one, deadly sin number one is not having adequate reference materials. So invest in a reference book, and there are many books out there. So they're important in that the codes change, the nomenclatures change, the descriptors change, so that in order to understand clearly how those codes are to be applied in today's world, you need to have not only a coding book, but also something that describes the administration of the code as well. And there are many references there. So the American Dental Association has their coding book and their coding companion. Dr. Charles Blair, to be clear and to let you know, I helped in writing those books. I worked with Dr. Blair since 2010 to help produce those books. They are marvelous, marvelous references. And if you are either a subscriber in the Insurance Solutions newsletter or have a subscription to the Practice Booster website, those come with unlimited support. So if you have a question or need some help with either the use of the codes or selecting a code or how to administer them, these are great references that you can use to be able to make sure that you have the most up to date, the most accurate, and the broadest in its definitions and their explanations. Those are amazing to be able to use to utilize, to be able to understand the codes and how they're to be used. One of the reasons why it is so important that the ICD-10, those are the medical codes, and the CDT, they're updated every year. And anyone in the United States, it doesn't have to be a dentist even, it can be a team member, can submit a request to the American Dental Association to add or modify a code that exists or one that doesn't exist and you would like to have it existed. Those are all gathered by October 31st of every year. And then March, the following March, the Code Maintenance Committee comes together and they review all the submission requests to the Code Maintenance Committee to determine whether or not the code's going to be updated. So in the 2022 codes, we know what those are. We're restricted until they're published to be able to put those out publicly, but I can tell you there are a few codes that do make significant differences. Some of them have been updated to be more specific. For example, there were codes that described an appliance, and it didn't determine in the code whether it was a maxillary or a mandibular appliance. And there are codes added that do separate those. So it's easier for you to submit the code. It will be a maxillary appliance rather than having to add that information on the claim form manually to let the carrier know it's a maxillary or mandibular appliance. So there again, the codes are being cleaned up moving forward. Those are updated every year. And if you don't get a new reference every year, you will not know what the new codes are. So that's the reason why that is extremely important. So invest in current, complete, and accurate billing reference materials each year, and it will improve your reimbursement. It will help in your treatment planning, and it will make you more efficient in what you do. It'll keep you abreast of what you need to know, and will keep you accurate and moving forward. Number 2, inexperienced or inadequately trained team. Unfortunately, in dentistry, I think we're suffering, as everybody else in the country is suffering, a shortage of trained individuals to be able to work. And dentistry, for some reason, we're guilty of hiring and not necessarily training appropriately. We'll put a person in the position, and maybe they're trained by the person that they're replacing for maybe a week or maybe 2 weeks, and they are then expected to be in that position and do it perfectly with minimal or no training. That's inappropriate. It will put a strain on the practice. It can put you at risk when that person who is doing the billing and coding for you is untrained. That claim that you send to the insurance carrier is a legal document, and it has to be accurate in all its areas. If it's inaccurate, there could be a problem. One of the things I learned during my trial was the definition of intent to defraud in my case. I knew it meant that if you submitted a claim for a patient you never saw for services that you never did and knew that you were doing that, that would be intent to defraud. The thing that I didn't understand was the broader definition of intent from a legal standpoint. From a legal standpoint, intent is expanded into what is called blind disregard, which means if you continue to do the same thing, making a similar mistake and not having systems to identify and correct those mistakes, that is considered blind disregard. And in the legal world, that is intent to defraud as well. So there's no such thing as an innocent mistake. So it's very important that that individual who is responsible for submitting the claim is well trained. They know exactly what they need to do. They know how the codes are to be used. They should know how to document appropriately so that that will be in the clinical record, so that if anybody afterward does an audit or comes in and looks at what's done, it's important that everybody knows what is expected of them. So everybody needs to be experienced and trained, and that training is ongoing. What might be true today can change drastically tomorrow. In our dental world, how has dental insurance and reimbursement changed over the years? It has been incredibly fluid in the way that you submit claims, and it's ever changing. What insurance companies will pay for, what they will not pay for. It's an ongoing learning experience that you need to be very active in making sure that you're trained and the team is trained and everybody's on the same page. They know what the expectations are and everybody is in that position. And that may take some time. And kudos to you. I'm preaching to the choir. You're here at this webinar. So you're learning, which is great. It's an ongoing experience that you continue to learn. So there are so many people out there that are in the position that just don't invest their time, energy, and effort in learning and moving forward. So all your teams should be encouraged to grow and to continue with continuing education. And as I said, I'm probably speaking to the choir here because you're here to learn. You're not that person who doesn't learn or doesn't care to learn. We need to be lifelong learners. Dentistry has changed. I started my practice in my grandfather's hardware store in 1981, which will give you an idea of how old I am and how long I've been in dentistry. When I first started in dentistry, insurance was just getting started. There was no such thing as a fee schedule. There was no such thing as a PPO. I look back at it as the golden age of dentistry, but that's changed drastically in today's world. So in that first 15, 20 years, there was very little change. But in the past 10 years, dentistry, especially as it relates to reimbursement and benefits in the dental world, they have changed so much in that period, and it's going to continue to change very rapidly. So invest in lifelong learning. Just because you're an expert today, if you don't continue to learn and grow, you will not be an expert tomorrow. Once that individual is trained, then stand back and let them do their job. Doctors, do not micromanage your teams. If it's an office manager who has deferred that billing piece to somebody else, teach them, train them, but then trust them. Also verify. And we'll be talking about some of the things that you need to look at later on. But ultimately, that individual who is in your practice, are they valuable? Yes, they are. And make sure that you value them by trusting them and giving feedback. Lastly, praise and celebrate growth and improvement. Things that are tracked improve. So there is a system we'll be talking about where you should monitor and make constant improvement as you move forward. But when you see some improvement, it's time to celebrate. Dental teams, I'm going to give you a little behind the scene information about dentists. We were in dental school taught to find what is wrong and then try to fix it. And that bleeds into our lives, unfortunately, in that we spend a lot of our life looking at other individuals and situations and only seeing the bad. I want you to think a little bit out of the box and look at the positive and recognize that and give feedback, positive feedback to those individuals who are meeting or exceeding expectations. That's very important. Issue number 3, and I'm a big proponent of this, is documentation. There are so many times I see that documentation is non-existent or inadequate. That clinical record is a legal document that will get you paid, will protect you, will give you the information that you need or anybody else who subsequently treats that patient. So we need to be very aware of what should be in that clinical record. And I use the acronym SOAP to keep our documentation and claims clean. SOAP is an acronym. S means the subjective part. That is what the patient tells you. It may be the chief complaint. It may be a history the patient has had of illnesses or of dental disease, and they can communicate to you the severity and the location. The health history is a subjective piece of the clinical record. Anything that the patient tells you, that is subjective. So that should be listed on the clinical record in the S area, in the subjective area. The O stands for objective. That is something that we as a dental professional or dental team collect and make a part of the clinical record. So that might be a blood pressure. That might be the findings during that screening that we do now for COVID before they come in. It might be the periodontal charting. It might be the health history information review. Anything that that team does is objective in determining what has gone on in the patient's mouth, what you're seeing in the patient's mouth, what that professional is observing in that patient situation. The third part, the SOA, the A part, assessment, that is where you take the subjective comments that the patient has made, the objective observations that you have made in the evaluation of the patient, and then you come up with a diagnosis. Before any treatment is delivered to a patient, any treatment at all, there should be a diagnosis that is documented in that clinical record that would establish the need for that treatment moving forward. So that would be, for example, a complete periodontal diagnosis has three variables. It's either mild, moderate, severe. It's either generalized or localized, and it's either chronic or acute. So a complete periodontal diagnosis is, it might be severe, generalized, chronic periodontal disease, or it could be gingivitis. And the same variables go with gingivitis: mild, moderate, severe, generalized, localized, chronic or acute, inflammation. As far as the staging and the AAP, the American Association of Periodontology, have a whole new criterion as far as the staging of the periodontal issue. It's also good to add that to that assessment as well, part of the diagnosis, to make sure that you capture all the information in a way that it can be conveyed to the insurance company more easily and clearly. The last letter, the acronym SOAP, is plan. That is your treatment plan. And the treatment plan should be driven directly from that assessment. And I encourage you, when you put together your treatment plans, put together three separate groups. Group number one is the areas, the things that are acute, that you could have a very significant periodontal infection or might have an abscess if the area is not taken care of. So number one would be those things that are acute and are, from a dental point of view, dangerous to the health of that patient. Number two would be the things that you recommend to take care of a disease process. Patient may have periodontal issue going on. It may not be so severe that it's going to bring some abscess in the next month or two, or it may have a cavity that's not terrifically large but needs to be treated. That would go in group two, where you're treating a disease process. And then the third group is what you recommend to the patient to put them back as ideally as possible. So that might be implants, that might be bridges, that might be partials, something that the disease process in the patient's mouth has been arrested, but they're not fully restored. So these would be the things, the recommendations that you would make in that treatment plan to put them together perfectly. And that helps to triage the treatment. You determine always the acute part of the treatment plan should be addressed first, the disease areas next, and then the ideal restorative pieces would be third. However, it's okay if the patient has, say, tooth number 14 has a very large area of decay. If it's not taken care of very, very rapidly, there's something very negative is going to happen. But they also need a bridge from 12 to 14. Can you do the bridge as well as treating the tooth that is badly decayed? Yes, you can. Quadrant dentistry is fine, but you would not do, for example, bleaching when a patient has something that's acute that needs to be done. Technically, that would be supervised neglect. The argument could be made is that you ignored the thing that the patient really needed to provide something they didn't need, and that would be failure to treat or failure to diagnose, so you need to be careful about that. If it's not documented, it didn't happen. If it's not in the clinical record, it didn't happen. So if you do not give the person who is doing the billing and the coding adequate information, I can guarantee you're leaving money on the table. That person will be hard pressed to get, for example, a crown approved if you haven't given that individual the assessment of the tooth and the objective things that you've noticed in the tooth, the review of the radiograph, whatever that might be. If it's not in the clinical record, it didn't happen, and you just can't make that stuff up. There could be an issue if the clinical record does not have the information and the claim does. If you're audited and they, in that audit, take a look at the claim you submitted and the clinical record, and if they don't match, there's a good possibility they would ask for reimbursement of that payment to them in the event that the clinical record, which is the legal supportive information for the treatment that was provided to be billed, then there could be a problem there. So be careful. A clean claim has all accurate information and supporting documentation to show treatment was necessary and was rendered. So I encourage the documentation to be so well done that you can either do a screenshot and attach it to the claim as supportive, or you can cut and paste onto a document to be able to send with the claim. Those are the practices that get the highest reimbursement rates. They are paid more rapidly, and they undergo fewer audits because when they review those situations, they see that the documentation is absolutely adequate to be able to support the treatment that was provided. So the foundation of all reimbursement comes from that documentation. And oh, by the way, the doctor has to sign that clinical record, and hygienists can sign the record, and I encourage them to do that. But doctors, you need to review and sign the hygienist record, except in those states where the hygienist can diagnose and practice independently. There are 4 of those now. So unless you live in one of those states, the doctor needs to sign the hygiene note as well. Pro tip: inadequate or non-existent documentation increased risk, prompts insurance company audits, and could lead to prison time. Ultimately, if your clinical record does not support the need and you've billed for something, you cannot substantiate the need for the reimbursement from that clinical record. There could be an issue that it was not supported, did not need to be done, and you're providing treatment that was not necessary. So just be aware, you have to be careful about that. One of the things I see that makes things more difficult for the people who are doing the billing and to be able to generate treatment plans that are accurate and collect at the time of service if you do not have accurate fee schedules in your software. And this is difficult to do, but if you have a criteria and a protocol to be able to add these or to plug these in and you keep them up to date, then you will have more accurate information. When you do your treatment plans, you're going to be able to give that patient an accurate estimate of their part collected at the time that the work is rendered or prior to. Anytime you get an EOB back and the fee that the EOB paid is different than the fee schedule you have in your software, that should trigger a bell and say, okay, we need to look at the fees. The fees could have changed. We need to update and be accurate, because if this fee is different, there's a good possibility that other fees are incorrect as well. So one of the things that you need to do when you get an EOB back and the fee that's in the software that you've loaded in your software is not the fee that was actually paid, that should trigger you're going into the software, looking at the fee schedule, comparing it to the current fee schedule, and updating it as necessary. Also, you need to document in your software if there is a limitation that you weren't aware of. For example, limitation period you thought was 5 years, it's now 7 years. So anytime you get something back from the insurance company where you've made an error, where the information in your software is not correct, go in and correct it. So by doing that, by giving accurate information to the patient, collecting at the time of treatment or prior to, it reduces the debts and credits to patients. It's never a good day when you have a fee schedule, you've quoted to patients an X amount for the treatment out of pocket, their percentage, and you send it to the insurance company. you get it back, and in fact, the patient is going to end up owing $2 more. Is a patient ever happy when they get a bill once they think that they've paid their balance in full? That's never a good day. That's never a good conversation. That does a lot to sever that relationship between the practice and the patient, because the patient feels that they were lied to. Even though you may have said this is an estimate, we're estimating, this may change. They don't hear that. They hear that they have they've paid their balance and they aren't expecting a bill, and it usually will make them a little bit wary about what's going on. So be careful about that. Treatment plan presentation, there again, you need to be as accurate as possible when you're sharing with the patient that patient portion that you expect them to owe. And your practice management software can do this accurately if you have the correct fee schedules into the software. So, like I said, anytime you get an EOB back where the fee that you have in your system is not the same fee as was paid, that should trigger well, I need to go look at this fee schedule. We may need to update it. Update the PPO fee schedule to accurately show on the patient ledger, but bill the UCR to the insurance companies. This will give you more accurate monthly production numbers. So there are 3 reasons that you need to put your office fee on a claim, even if it's a PPO where you're going to write it off. Number 1, insurance companies look at the average fee for offices when they calculate their UCRs. So because you don't want to have the write-off, it can get, I get it, the accounting piece can get kind of aggravating to have to go in and write off the difference between the PPO fee and the office fee. However, if the insurance companies are looking at their average fee for a service to determine whether or not they might raise that fee or lower that fee, if you use that PPO fee, when they look at what you're submitting to the insurance company, they're paying 100% of what you're billing from their view. They don't know what your full fee is. So they'll look at that and go, we're paying a majority of our dentists their full fee, so we shouldn't raise it. We might need to reduce it 20%. And to be honest with you, I've seen more companies come back and start reducing those. And I'm thinking it could be tied back to the fact that there are several offices that do submit the PPO fee when they submit claims to the insurance company so they don't have to do the write-off. So that's one reason. Number 2, if you have more than one insurance and you write off or you only bill for the PPO fee, different insurances have different fee schedules. So there's an opportunity to get more money from the second company if you use your full fee. However, if you've submitted the PPO fee, you won't have any opportunity with the second or some insurance to collect more than that fee schedule. So that's going to keep you from doing that. And the thirdly is you use your full fee to help you to understand how much you're writing off. Sometimes we look at those PPOs, and of course, their selling point is they're going to send you so many more patients. My experience is that it may or may not happen. If they've had dental insurance for a number of years, you're not going to see a whole large number of new patients because patients will have established a dentist of record. So it's not probably going to send a whole lot of people to you unless it's a new plan or a new business that's opening. But that full fee is going to help you calculate what percentage you're writing off to determine, is that PPO one that you need to stay in network with, or you may need to go out of network because you may actually be losing money each patient that you see. So be careful about that. Inaccurate claim information. Make sure that all areas of the claim form are accurate when you're entering the information from that insurance card. And I encourage, I still see a lot of intake information from patients, and you're asking for the insurance information for them to fill it out on the intake information. Never do that. I encourage you with that patient, especially if it's a new patient or a patient with new insurance, I would ask them to take a copy and either email or text it to you so that you'll have a copy of that insurance card prior to their coming in, and you can verify benefits. You can determine whether or not that is active account, all that before they come in the front door, and that'll streamline that process. So make sure that your insurance information is accurate, and all the boxes on that claim form need to be accurate as well. So the NPI area needs to have the correct billing entity. The treating doctor, it needs to be the treating doctor with their NPI in that box as well. It needs to be accurate. And I see sometimes, especially in today's world, we see a number of associates coming in and out of practices. And I've seen associates come in, the owner doctor and maybe a couple of doctors are in a PPO plan, and the new doctor has not been credentialed yet. So they instruct the billing people to use the owner doctor or one of the credentialed doctor's information in the treating provider box in order to be able to receive in-network benefits. That's a fraudulent claim. That claim form has to be accurate. The dentist who is identified in the box as provider of service needs to be the accurate dentist who did that, or supervise the hygienist that provide care who did the evaluation with the hygienist. That doctor needs to be identified in that box as well. So make sure birthdays are correct, make sure the claimant information is correct, the insurance primary and secondary information is correct. Go through that to make sure that the claim information is accurate. There are a lot of denials due to incorrect information. It really is one of the largest reasons why that claims are denied. Even a digit or a period or the smallest item, if it's in the wrong place, can cause problems. And getting the information will help. And teledentistry is one way that you can do that. So I encourage you to use teledentistry, not necessarily as a diagnostic tool. Some states will allow you to do a limited evaluation over teledentistry. Most, from my understanding, most board of dentistries do not consider a virtual assessment of a patient to be a true evaluation. So when you're coding a teledentistry visit in a state where it will not allow you to do an evaluation, a good code is either assessment or screening to do those. But this is a good time to collect information. Doctors, I encourage you to contact the patients via Zoom or Skype or however you like to do it, to have a conversation and just to meet them and tell them a little bit about the practice and get to know you, so that relationship starts early in the process before they even get into the practice. And I've seen practices who have implemented this have cut their no-shows for new patients by 75% because the dentist has been in touch with them. There is a relationship that's been established there. So this is a good way to be able to do that. But like I said, coding for this, unless it's in a state where you can do a limited evaluation via teledentistry, it would be either a screening or assessment that you would do that. So value accurate information. Have a copy of the insurance card and the photo ID on file. Check and make sure that all the information, the legal name, and there again, this is a big deal. We have people who go by nicknames, or you may go by a middle name rather than a first name, but with the insurance carrier, in their history, the way that patient has been registered, it's the first name that they don't use. So if you send the claim in with the person's middle name and last name, there's a good chance it's going to be denied because the names don't jive. Date of birth are important in the ID from the card, needs to be exact. Like I said, they're not going to do any of the work for you. So the address, the group, the payer, the ID number, make sure that's all in and correct as well. So, and 65% of offices there on the right-hand side do accept some type of dental insurance at this point. So most people are involved with dental insurance. If you have a HIPAA secure texting service, ask for contacts. And I would talk to your field service representative to see, I think Henry Schein has a product that they have that is HIPAA compliant, where you can convey that information back and forth and be able to do that in a HIPAA compliant way. Make sure, in fact, that when you do secure information from the patient, or if you do that teledentistry meeting, then do it in a way that is HIPAA compliant. there's a free platform that's called Doxy.com. I think eAssist also has a compliant teledentistry app that you might reach out to find out if that's available. Those are all great. Number 6, incomplete narratives and or supportive information. So you need to be aware of those claims that need to have supportive information, a narrative or something else to be able to convey to that insurance company that the treatment was necessary, medically necessary. Ultimately, my friend Lois Manna says, go into obnoxious detail. So some of the things that you might look at: intraoral photos, photographic images. A picture is worth 1,000 words. A lot of times with core buildups, the x-rays may not show the extent of what is affected and needs to be removed when you're doing a crown prep. So especially for core buildups, I recommend that you do a pre-treatment photo. Then once all the old restorative material and damaged tooth structure has been removed and you're ready to do the core buildup, take a picture at that point so you can send that to the insurance company. They can see how much of the tooth is left. Narratives need to be complete. They should be generated from the clinical record. And you need to know the magic words. We don't have long enough tonight to be able to talk about the magic words, but many of the treatments that we provide have magic words. And back with core buildup, we were talking about the photos before. Core buildups, the magic word with the core buildup is retention, so that the narrative should indicate that the tooth would not be capable of retaining a crown without the core buildup. So retention is the magic word. And there's all kinds of magic words that you need to be aware of with the narratives. And let's face it, those claims are not being processed anymore. Well, most of them are not in the United States. They go overseas. And the people who are processing those claims, English is not their first language. It's their second language or maybe third. So they are given a list of the magic words that need to be contained in that narrative to trigger the, okay, we should pay this one. And retention is one of those words with the core buildup. Perio charting, there again, to get your perio scaling and root planing, complete with bleeding, recession, attachment loss, as well as probing. The 3 things that need to occur in the mouth that trigger the reimbursement for scaling and root planing: bleeding on probing. You have pockets 4 or 5 millimeters. Now, different insurance companies have different baselines, so 4 or 5 greater, and bone loss, and a minimum of 10% bone loss to justify scaling and root planing. So all those things need to exist, and you need to point them out or give them information that does contain that as part of it. Doctor's notes need to be complete, descriptive, date with a signature when they send it, if they're doing a copy of that to the insurance carrier. Sending clean claims daily with all necessary supporting documentation ensures timely reimbursement and steady cash flow to your practice. We have another poll here. I'd like to know, how often do you follow up on your outstanding insurance claims? So if you would go in and answer that question, how often you do follow up on those claims. Adam, I'll turn it over to you to let you go ahead and do that.
All right, the poll is running. Let's give it a little longer.
I see this all over the board. It's some people are very on it and are what I call OCD. They are crazy about making sure that they follow up, and other people not so much. So thank you for taking a moment and answering the poll question. I appreciate that.
Just a reminder, if anyone does have questions, please use the Q&A as opposed to the chat. We've got lots of questions coming in, and I'm afraid I might miss it if it's in the chat. So thank you very much. And it's actually pretty close between weekly and monthly. I'll go ahead and share the results right now. Daily, not so much, but weekly took the slight lead.
Ain't nobody got time to do it every day, unless you have somebody that's just dedicated to the insurance. And that would be like, I don't know, watching grass grow. But yeah, ultimately, every 2 weeks would be a great time to be able to do that. And it's important that you do that regularly. And to be honest with you, insurance companies, I go to the insurance companies' meetings and talk to their consultants, the ones that dentists who work for the insurance companies. And sometimes it's borderline whether or not they're going to approve it. They'll deny it just to see if you're going to be one of those practices to press the point and make sure that they that you're committed to follow up. So if you think that there is an opportunity to appeal a claim, always do it, especially if it's for medical necessity, because it's always reviewed by another dentist, so you have a different eye on it. And finally, the 7 deadly sin is no system to monitor and follow up on all open claims. Anytime a claim is not paid, it is harder to follow up on. That's why I say it's more important to do the work on the front end and get everything right when you send the claim in the first time, so you don't have to follow up on it. But there again, if you get a denial or delayed, it's important that at least every 14 days that you're working on those claims. And if you're doing the work you need to on the front end, making sure that it's accurate, it's all documented appropriately when you first send it in, you're going to have fewer and fewer of these denied or delayed claims that you're going to have to deal with. So we've gone through this like Grant through Richmond. So claim information to share in the morning huddle. Denied claims, reason for denials, dollar amounts, was it written off, how much should it be appealed? This is something that the team needs to be aware of, and they need to know what is causing the issue. And if they're part of the process, they need to be more active in either getting the information that's necessary or documenting more appropriately. Any delayed claims, reason for delay and the dollar amount, total outstanding accounts receivable to insurance, plan of action to eliminate further delays, denials, and unpleasant surprises. And when this becomes something that is very minimal, happens very infrequently, that is an opportunity to celebrate, because whoever is submitting those claims, we know it's tough. Are you able to do it more effectively and efficiently? In most cases, you can. But if you're one of those people who always get it paid and within a timely amount, you need a pat on your back, and I'm celebrating you today because you have worked hard. Celebrate wins. Never forget why we do what we do, and that's to change our patients' lives. And insurance is part of the process to make it so it's easier for them to accept treatment. It helps to offset some of their expenses, but it's important that we do that. And ultimately, that's what eAssist wants to do, delivering peace of mind by providing billing, coding services, and all those other ancillary services I described in the beginning. So I'd like a last poll. If you'd like to have someone from your team reach out to you and schedule a demo about eAssist billing services, demo's short, it's painless. It's one of those things, if you'd like to have help doing this, taking it off your plate, and certainly in our practices, we need to spend the bulk of our time with our patients, developing relationships with our patients so that they understand that we're about them, their health, their future, then the better off we're going to be. And this will free somebody up in the practice to be able to do this by offloading that to somebody else. So, Adam, you got that taken care of?
Yep, I'm going to leave it up for a little longer, but you can continue.
Cool. So I think we're ready for the Q&A. Hope we've got some out there. Hope it wasn't too confusing.
Oh, we've got plenty.
Good.
Yes. Let's see here. Can you give me the best options for getting common perio codes covered, assuming they have no missing tooth clause?
Common perio codes like the 43 scaling and root planing. Make sure that the documentation contains a complete periodontal chart that includes not only the probing depths. A lot of times I'll just see the probing depths sent in, make sure that it focuses also on bleeding points, and that the x-rays do show, and the x-rays standard of care for periodontal treatment would be a full mouth series. So if you're doing scaling and root planing, or a patient has periodontal disease and you're proposing scaling and root planing and you're taking a Panorex and bite wings, more than likely that will get denied because they will not have the adequate radiographs to be able to assess the bone levels. Panorex and bite wings do not give them adequate documentation for that. So the three things: the complete periodontal chart, x-rays that are adequate to be able to show the bone loss, and what was the third one? Bleeding on probing. Yeah, the periodontal charting. Yeah, so we're all good. That's what you would include. A periodontal diagnosis would be good, and staging would be as well. So there again, it would be chronic, severe, generalized periodontal disease, and that should be in the clinical record, the diagnosis for that treatment. So that would be all part of it. Great question. Thank you.
Is the doctor's initials after the hygienist's signature acceptable for validation? The doctor is doing the exam during the hygiene visit.
Right. Right. So it's better for the doctor to sign, but I understand a lot of times when the hygienist signs it, it locks it. So you should develop a written protocol in your practice that indicates when the doctor affixes their initials, that means that the doctor has reviewed and accepted, and for all intents and purposes in your practice, that is the doctor's signature. Now, that should be a written protocol. That should be part of that office manual so that everybody understands. So if somebody asks, well, this doesn't look like a signature, what in our office, this is our protocol. When the doctor's initials are affixed to the hygiene record, then that is in our practice has been developed as the doctor's signature. This is what the doctor's signature is. So yes, you can do it that way, but it needs to be written. It's just something you can't have an understanding. You're going to have something that somebody asked. You're going to be able to show them the protocol, and everybody in the practice should have read and signed that they understand. They have read and understand that that's what that means.
Do all doctors? Oh, yeah, we got a lot more. Do all doctors have to be credentialed? We have doctors that only work a few months.
They don't have to be credentialed, but when you accurately put their name on the claim form, it will be processed as an out-of-network provider. Even though the billing entity of it may be a doctor that is in network, they determine the in-network, out-of-network, the credentialing based on the doctor who provided care. So yes, they can. They don't have to be credentialed. Some insurances will require, if one doctor in the practice is credentialed, all need to be. Now that's rare, but you can call the insurance company and find out, in fact, if that's required. Some do, most don't. So you can have dentists or doctors who are credentialed and others are not. Now that makes it extremely difficult for patients. If they think they're seeing a doctor who is in network and in fact they have been assigned to a doctor who's not in network, that can be problematic. So make sure when that patient comes in and they are seeing a doctor that is not credentialed, that they're made aware so that they have an opportunity to decide if they want to go ahead with seeing that doctor or another one.
What is hard billing, and is it okay or legal?
Hard billing. I don't know what that is.
Oh, we stumped you.
Okay. Is it an acronym, HARD?
I don't know. It was spelled out, hard billing.
Oh.
If anyone out there knows, let us know.
Yeah. If you clarify, let me know. Yeah.
What else? You may have stated, but can we? Oh yes, there is a recording of tonight that'll be sent out. Where can I find? Yeah.
Go ahead. I think they get a copy of the presentation if they want it as well.
Yep. Where can I find requirements for insurance companies to approve a crown?
Most of them will have the criteria necessary on their website. So I would go to the website first. They will usually have a portal for doctors, and usually listed on the website, there'll be the criterion that they require, what they require to justify the need for the crown.
And then part two of that question, also for a core buildup, what counts as tooth does not have enough retention, as nowadays a flat surface could have enough retention with bonding?
Correct. So the ferrule, there needs to be enough parallel wall, and insurance companies, anything less than a third of the normal height. So different teeth will have different height, but a third of the tooth remaining, that you're able to get the parallel walls so that there is a bit of parallelism. Anything less than having a third of the tooth with that amount of ferrule is considered a need for a core buildup. However, more insurance companies are making the core buildups part of the crown. They just have developed a policy that they consider core buildup part of the crown. So in the case that it's denied, in a situation like that where it's just a non-covered service, there's no way to be able to get around that. Same thing as limitation periods. If they will not replace a crown for 5 years, then if it's 4.5 years, there's no narrative, there's no amount of begging or information that you can give the insurance company that will have them pay it. That's a hard and fast rule. Even though the patient may definitely need a new crown, they're not going to pay for it.
Right, moving on down. What are the rules about doing scaling and route planning and a prophylaxis? Can they be done the same day? Does one have to come before the other to get the benefit?
Yeah. Patient who needs to have a scaling and route planning, that would be done first. You would triage the most acute need to be able to get that paid. So you would do the scaling and route planning, the 4910, and the 4910 afterward. You wouldn't do a prophy afterward because it would be a periodontal maintenance that would be done after it. So if you have a patient who you're doing 2 quadrants, they only have 2 quadrants that are necessary, scaling and route planning is done first. And then at the follow-up, that'd be the 4910 that you would do that. So the scaling and route planning would always be first, because that's where the patient has the greatest need, the most prevalent disease, and then the maintenance afterward. Once you're a scaling and route planning patient, you'll always have periodontal disease. And I have a good friend, Pam Throw, who is the billing specialist for the American Association of Periodontology. And if you ever suggest to her that you could alternate the 4910 and the prophy, she stands up on a chair and screams. It would be as if the patient had periodontal disease, then didn't have it, then had it again, then didn't have it again. So the prophy, by definition, is a preventive service, and it's to treat inflammation, gingivitis. The 4910 is a treatment code that maintains the periodontal status of a patient with periodontal disease. So once bone is gone, that's a perio patient for life. Bone doesn't grow back. So 4910 would be the maintenance after the scaling root plan. Great questions. Perio is very confusing. So I'm going to chase a rabbit again. I have ADHD. That's the only test I've ever taken in my life and scored 100% on. So I aced that test. A lot of people are confused a little bit about the debridement or debridement, depending on your way of defining it, emphasis on what's syllable. The debridement is done when you can't come to a definitive diagnosis about the periodontal status. So the trick to the debridement, you do it first, and you can do all other components of an evaluation, but you can't do your periodontal diagnosis. So you've not completed the service. It's not billable at that point. So you bill the debridement first, then you bring the patient back, and then you can complete the periodontal diagnosis and bill out the evaluation. If you bill the evaluation on the day that you do the debridement, that's not going to be covered more than likely. They'll pay for the evaluation, but not the debridement. As far as the sequencing, it would be debridement, next appointment evaluation, and then either prophy if the patient only has inflammation, or scaling and root planing if the patient has periodontal disease. So it can go either way, but the debridement is standalone, then the evaluation, and then the appropriate treatment is done at the subsequent appointment.
Can you text a patient that they have a balance if they do not pick up your call?
When you have the patient come in, when you do your HIPAA release, I would encourage you to add a line that, is it okay to contact you via conventional email? And if they say yes, or if you say, is it okay to text? And if they click yes, then yes, you can do that. You can text them if you have a HIPAA compliant texting platform, yes. But by regular text, that's not HIPAA compliant if they haven't given you permission to do that. And like I said, I just add those. When there's usually a line, who you authorize to get your healthcare information besides yourself. But I would add a couple of lines. Is it okay to convey information via email Is it okay to convey information via conventional text? And you can use your regular text, and they've given you permission to do that, and it won't um, risk the HIPAA issue. But otherwise, you can do it, but you need to do it in a HIPAA compliant way with a platform that can do it that way.
How do we get a claim to be paid that is not a covered benefit, such as erosion?
You can't. It's one of those, if it's in the erosion, attrition, they typically don't pay those ever, and that's in the clause of the insurance, and there's no way to get around that. But what I suggest you do, in the event that not only is there erosion, if there's also fractures, focus on the fact that the tooth is fractured. Insurance will pay for repair of fractured teeth if it's fractured into dentin in most cases. So I just not even mention the fact that it was eroded or abraded or whatever the issue is as far as a parafunctional habit, because there's no way to get that paid. It says in the insurance, this is not a covered benefit. However, if the tooth is also fractured or another issue, if it's decayed, focus on that rather than the fact that it is abraded or worn.
Most patients do not know exact dates of placement regarding existing crowns or bridge. They can give a year, but most don't know the month and day. How do we submit that as far as the date last done?
I would have the patient estimate as best they could the day of the year that it was done. And I would identify when you say patient indicated date of last payment was X, whatever that is. Don't come up with a number on your own. Have the patient give you their best estimate on what that is. If you can contact the prior treater and be able to get that information, that's one way to be able to do that. Reach out to the dentist who actually did it. Maybe if it's the same insurance, they have it on file, so they can do that if the patient's had the insurance for that long. But in the event that you can't get either of those things, then go ahead and have the patient guesstimate to their best knowledge what that date was.
If you get denied something like SRP or buildup, can you keep the patient portion and write off the rest?
The patient. If you're in network and if they've denied it and not disallowed it, yes. If they disallowed it and you're in network and they say you can't collect it, then you can't. You're contractually obligated to follow the directions. There's a difference between denial and disallowed. Disallowed means that they're not going to pay for it and you can't bill the patient. Denied is the insurance is not going to pay for it, but you can bill the patient. So it depends. If it's disallowed and you're in network, you can't. If you're denied and in or out of network, you can collect from the patient.
All right, got a couple fee schedule questions for you.
Okay.
Number one, can an insurance company change your fee schedule? Is it not a legal contract? And number two, do you have any tips for updating fee schedules for out-of-network insurance companies when the company is not willing to share their fee schedule?
Yeah. Question number one. What was question number one? Tell me again. I'm sorry, blitzed out.
Yep, no problem. Can an insurance company change your fee schedule? Is it not a legal contract?
It is a legal contract, but the legal contract you sign gives you a fee schedule, and it also has a clause that allows the insurance company, gives them permission to change the contract at their whim with 30 days notice. So it is a contract, you signed it, but however, part of that contract gave them the right to change it at their leisure. So it is legal for them to do that because the contract you signed said, yes, it's okay for them to do that, and you're okay with it. As far as getting a fee schedule, I would encourage you, the patient can get a copy of it. Sometimes that's a little bit harder to do, but if a patient is an employee of a larger company that's providing the insurance, that larger company HR department will have that fee schedule. You can reach out to them and they will more than likely provide you the fee schedule that you can update from. But there again, if the patient is privy to the fee schedule, they can ask for it and get it. Sometimes if you're out of network, they won't give it to you, but the patient will have access to it.
All right, let's just do a couple more here. Should I bill procedures? Should I bill procedures that I know are not going to be covered if I'm in network with that insurance?
If the insurance company requires it, you do. Most in network will say they want everything billed, whether they pay for it or not. So it depends on the contract. The reason why they generally order you to do that is they want to make sure that they are able to maintain their limitation period. So, for example, you're going to take x-rays on a patient and you don't want to bill the insurance, it's not going to get paid. But the insurance company says you have to, because then they start tracking the limitation period from that set of x-rays that you took that they aren't even going to pay for. So there again, it depends on the contract. If the contract stipulates that you do, and most in-network will stipulate that they want everything submitted. If you're not in network, or if the company is one that says that you don't have to submit everything, then you don't have to. That's driven by the contract.
If a patient is having amalgams replaced to composite, not due to decay, do we have to note that on the claim?
You ultimately, to disclose the insurance company, that is basically a cosmetic service. If the amalgams are functional and they're being replaced because the patient doesn't like the amalgam, then that would be considered an optional service, and that's a whole different lecture. There's a way to be able to get that done so the patient agrees to pay it out of pocket. That would be a non-covered service. And then depending on the state that you're in, if you have non-covered benefit legislation, it may fit under that heading as well. So the patient would pay that out of pocket. Alerting the insurance company, there again, it depends on if you have to submit everything by contract to the insurance company. You would need to submit that. In the event that you don't have to, one of the companies you don't have to submit that. But like I said, even if you submit it to the insurance company, more than likely that's going to be considered a cosmetic service and an optional service that the patient would need to agree to pay out of pocket. Then if you go through the steps, then you can bill the patient, and the patient would be expected to pay for that regardless of what the insurance company tells you.
How should you handle payments from primary and secondary insurance companies?
So with a patient with primary and secondary, or even with tertiary, never do any write-offs until everything is paid. Submit your full fee on all claim forms. And then once all the insurance companies have paid, look at what you've received. Patient will always get benefit of the lowest fee schedule. So for example, your crown fee is $1,000, and I'm just throwing numbers out there. And the lowest fee schedule is $600. So you get all payments, and you've gotten $550 from the insurance companies. The patient would pay $50. If you got, in combination of all the insurance companies, $800 with the lowest fee schedule, $600, you write off from $1,000 down to $800, and the patient owes nothing. You can keep up to your full fee schedule. Patient's going to get benefit of the lowest fee schedule as long as the payment is lower than the lowest fee schedule. But you can keep up to your full fee in your practice. And sometimes the patient may actually make money on coming to the dentist if they have a supplemental plan. Supplemental plans are hard to figure out. If it is a supplemental plan, that patient may make money. That's the only instance where the patient may get money back. In the event that it's not a supplemental plan and all the payments come to greater than your office fee, call the last payer who put it over your office fee, explain, note who you talk to, when you talk to them, because they record it, they can go back and listen. And whatever that individual tells you, if they say we've not made a mistake, it's your money, keep the money. The patient may, if it's over your full fee, give the patient back their portion, and you're paid at 100%. Or, if they say send the money back, send the money back. Do whatever they say, make a notation who you talk to, when you talk to them, and what you were advised to do by that person. And in the event that they say it's your money and you give money back to your patient, have the patient sign a release that says, should the insurance company come back and determine that they did pay an error and they want the money back, that patient has the responsibility of repaying the money. So you can get the money back. They've made that stipulation that they're willing to get that back. These are great questions.
Well, with that said, we are a little bit over time, and we've got a lot of questions left, so I don't think we're going to get through all of them tonight. But I've got one more question queued up here. But if you do have additional questions that we did not answer, please feel free to email webinars@henryschein.com, and we will certainly route your question to the eAssist team. So the final question of the night is, how do insurance companies get away with substitute coding? For example, amalgam for composite and posterior teeth.
Yeah, they remap a lot. A unfortunately, that is also part of the agreement. It gives them, if you're in network, it gives them the right to do that. If you're out of network, they can do that, but you collect from the patient the difference when they do that. They call it remapping. So rather than paying for a bridge, they pay for what's called the least expensive alternative benefit, the LEAP clause in the insurance plan, which means that they're going to pay for the least expensive thing they can pay to provide the treatment. So if there's a cavity, amalgam is the least expensive. If they have a missing tooth, a partial is least expensive. So a lot of the PPOs have that clause in the insurance plan that allows them to pay for the least expensive alternative benefit. And the doctor who has signed that agreement agrees that they will accept the fact that the insurance company is able to do that. Unfortunately, there are very few doctors who read those contracts cover to cover. And oh, by the way, I told you that insurance companies can change the contract at their whim. And most of the time they alert you in a letter. And that's one of those you think is a junk letter from an insurance carrier. You toss it in the trash can, when in fact that letter may have contained in some of the small print the notification that they're reducing your reimbursement by 20%. And if you don't read those, you're probably going to be surprised when you get that 30-day afterward, you get the first new claim processed and it's 20% lower than your other fee schedule. So there again, make sure that you read the contract, you understand that the limitations and the restrictions that are in that contract, because you're obligated to them if you sign the contract. Maybe time to take a look at that contract and figure out maybe it might be good time to go out of network with that plan. And there are ways of being able to do that painlessly. If you're thinking about doing that, the consulting division at eAssist, we have a specialist with helping doctors transition out of PPOs and reducing the impact that has. So that might be something you would look at.
Perfect. Are you all questioned out?
Hey, I do this for a living. I love it. I'm a billing coding geek. It kind of lights my fire and I enjoy doing it.
All right. Well, thank you so much, Dr. Shelburne, for all of the crucial information and, of course, the excellent presentation. Thank you to eAssist for sponsoring tonight's webinar. As I mentioned earlier, we did record this webinar, so the recording will be sent out within 1 week of today via email, and included in that email will be a copy of the slide deck tonight. Like I said, if you have any additional questions, please feel free to email us, webinars@henryschein.com. Or if you want to look for upcoming webinars, henryscheindental.com/webinars. Thank you all so much for attending tonight, and have a great night.